Hello doctors, welcome back to Jabstudiesmetfun, and we are here for medicine part 17. Now this time what I'm going to start doing is that instead of keeping a separate PPT slides, what I'm going to do is whatever lectures I had studied from what my notes were, we're just going to talk about that. Which means it's going to be much more at present of what I did. Along with that, we'll save a lot of time and we can make much more videos. So in this medicine part 17, what I'm going to do is I'm going to talk about the parathyroid gland, the hyper and hypoparathyroid issues, the thyroid gland, hypo and hyper, and along with that, potassium related issues as well. So without further ado, let's start. First thing what we're going to do is we are going to talk about the parathyroid gland. Now with respect to the parathyroid gland, doctor, what you need to know is what are the basically how many number of parathyroid glands are there. We have total 4 number of parathyroid glands, right? We have 4 number of parathyroid glands. Second is what is the location of the parathyroid? It is basically present at the posterior surface of the thyroid gland. Talking about the embryology, a very important anatomy question. The superior parathyroid gland develops from the 4th pharyngeal pouch. On the other hand, the inferior parathyroid gland develops from the 3rd pharyngeal pouch. If you talk about the blood supply, the parathyroid glands are mainly supplied by the inferior thyroid artery, okay, and the venous drainage is thyroid venous plexus. If you talk about the histology, there are 2 cells, and the main cell which you talk about in the parathyroid, which secretes the parathyroid hormone, are the chief cells. The chief cells are secreting the parathyroid. Oxophic cells are the ones which are larger in number. Now, very important about this is the parathyroid hormone. Now, what does the parathyroid hormone do? In simple words, let's talk about that. If you talk about the parathyroid hormone, what it does is it increases calcium and it decreases your phosphate level, and we're talking about the serum phosphate and the serum calcium level. How does it increase calcium? It increases calcium by causing bone resorption. What is the meaning of resorption? Basically, it is removing it out from the bones. And remember, the resorption and reabsorption is different. It also causes calcium reabsorption. Now see the reabsorption from where? From kidneys. That is very important that you need to know. Okay, so this is the main thing. Also remember, doctor, that calcium is inversely proportional to phosphate levels. So wherever you will see the calcium is elevated, the phosphate has to go down. Now let's talk about, with these basics, at least 10 marks are covered from this. We have covered the anatomy. Let us talk about the medicine part, that is primary hyperparathyroidism. Respect of primary hyperparathyroidism, the main cause is going to be a tumor, which is an adenoma, a parathyroid adenoma. So if the parathyroid adenoma is more, the PTH level is going to be more. If the PTH level is going to be more, calcium is going to be more and phosphate is going to be less, as the inversely proportional rule. So basically, if you want to remember the classic history of hyperparathyroidism, remember this mnemonic: moans, groans, bones, and stones. Basically, if you talk about the moans, it is related to, because of hypercalcemia, you will have psychiatric issues, hallucinations, the patient can get depressed, fatigue, a lot of that. Groans, G for groans, G for gastric intestinal effects. Because calcium is going too much and calcium causes contraction of the sphincters, patient will suffer from cramping, abdominal pain, constipation. So C for calcemia, C for calcium, C for constipation. Bones, because parathyroid causes bone resorption. Bone resorption basically means it is removing out all the calcium from the bones, and that is why the bones are getting weak. Patient can suffer from osteoporosis, osteopenia, and then last one is going to be stones. Stones are the calcium stones which are formed, and these are the renal stones. Now talking about the renal stones, it can get stuck in the kidney, get lodged in the ureter or the urinary bladder. If you talk about the kidney stones, the classic pain will be, they'll have flank pain. Patient will say flank pain which is radiating to the front. In males, it can radiate to the penis, and in females, it can radiate to the vulva. If you talk about the bleeding, they will say that yes, while urinating, they'll have hematuria because of the damage caused by the stone. So these are the classic history of renal stone. As I told you, calcium can cause spasm of the sphincter of the gut, thereby patient is going to suffer from a classic thing which is constipation. So C for calcium, C for hypercalcemia, and C for constipation. The psychotic moans, calcium level, if now the normal calcium level, very important, you need to know, is around 8.5 to 10.5 milligram per deciliter. If this level exceeds more than 15 gram, then a patient can die with the cause of systolic arrest. because too much contraction is going on and patient can die because of systolic arrest. If there is a systolic arrest, then there should be something which is a diastolic arrest, correct? And diastolic arrest is because of hyperkalemia. Very important, hyperkalemia. So remember, if they say patient died with the cause of systolic arrest, what is the electrolyte abnormality? Hypercalcemia. If a patient dies with diastolic arrest, electrolyte abnormality is going to be hyperkalemia. Okay. So over here I have talked about the mnemonic, which we talked: moans, groans, stones. All of this is written over here. You can read through whatever we just described. It's all about that. Next, if you see, this is a scan. This is a SESTA-MIBI scan, which is used for to detect the parathyroid adenomas and tumors and all. All right. So if you'll ask, what are the electrolyte changes which we already discussed with respect to primary hyperparathyroidism? Remember, if parathyroid hormone is going to be more, calcium will be less. So calcium is going to be more, and because calcium is more, and we told that calcium and phosphate are inversely proportional, so the phosphate is going to be less. And now there is another thing, this is SAP. SAP stands for serum alkaline phosphate. Now in case of hyperparathyroidism, SAP is going to be elevated. Now what is the reason why serum alkaline phosphate is elevated? See doctor, because parathyroid hormone is going to get activated, calcium is going to increase. Now why calcium is going to increase? Because from the bone it is going to take out calcium. If from the bone it is going to take out calcium, the bone is going to get weak. And in our bones, there are cells which are known as osteoblasts. Osteoblasts are going to strengthen the bone again. And whenever this gets activated, it secretes serum alkaline phosphate. That is why serum alkaline phosphate is elevated. In short, if you don't want to remember the mechanism, just remember whenever parathyroid hormone is going to increase, serum alkaline phosphate is also going to increase. So remember, if they will have you this clinical vignette, that patient has hypercalcemia, hypophosphatemia, and the SAP is elevated, you are talking about primary hyperparathyroidism. Next, if you talk about the parathyroid PTH assay, the PTH assay, because parathyroid is anyway elevated, is going to be elevated. Last, tumor localization, which we just now saw over here, this with the help of SESTA-MIBI scan. A SESTA-MIBI scan is a classically a technetium-99 scan. That also you have to remember. All right. Now it's going to be the management with respect to hypercalcemia. The first step which we have to do is that we have to reduce the calcium with respect to fluids. So basically, what we're doing is we're going to dilute the entire blood. Thereby, the concentration of calcium is going to go low. So that is the first step. That is normal saline. Second step is furosemides. Furosemide, which is known as Lasix, is basically a loop diuretic. Remember, Dr. Saab, that Lasix, which is furosemide, is going to cause excretion of calcium and also potassium. So remember, whenever there is hyperkalemia situation or hypercalcemia situation, we are going to give furosemide. The drug of choice with respect to hypercalcemia is going to be your bisphosphonates. And bisphosphonate classic examples are going to be ibandronate and zoledronate. Zoledronate is a very good drug because what is there is the route is going to be IV, and you just have to take this once a year, literally once a year. So that is zoledronate. I remember a pharmacology PYQ question. So remember, with respect to hypercalcemia, the first step is normal saline, and the drug of choice is going to be bisphosphonates. Now what does bisphosphonate basically do? Bisphosphonate basically prevents bone resorption, and bone resorption is mainly done by cells known as osteoclasts. So bisphosphonates prevent the functioning of osteoclasts by inhibiting an enzyme that is known as farnesyl pyrophosphate synthase. So we are trying to bring biochemistry along with that. All right. Another thing is calcitonin. Calcitonin causes increase in calcium levels. So you can do a calcitonin nasal spray. Eventually, you have to hemodialyze. Even after these all things are not working, you can do hemodialysis. And even after this, eventually the mainstay is going to be surgery after your pre-anesthetic checkup. So remember, first thing is going to be normal saline. Second thing is going to be your loop diuretics. Third step, drug of choice, ibandronate or zoledronate. Fourth step is calcitonin nasal spray, and the fifth eventually is going to be hemodialysis. Okay, so that is all about primary hyperparathyroidism. Remember, let's go quick review. It is because of a parathyroid adenoma, PTH increases, calcium increases, phosphate decreases. On the investigation, SAP is also going to increase. Remember, whenever parathyroid is increasing, SAP will also increase. Investigation of choice is SESTA-MIBI technetium-99 scan. You will talk about the management. First step, normal saline. Drug of choice, bisphosphonates, hemodialysis is also done. So we're done with primary hyperparathyroidism. Let's talk about secondary hyperparathyroidism. Cause of secondary hyperparathyroidism is going to be chronic kidney disease. Now why? Chronic kidney disease is responsible for the conversion of vitamin which is coming from the sunlight to active form, which is vitamin D3. If vitamin D3 is less, calcium will be less. If calcium will be less, because of the feedback mechanism, it will go and our hypothalamus, then pituitary gland, and then furthermore more PTH is going to increase. So that is why remember that PTH is going to increase in case of secondary hyperparathyroidism. The mechanism is because of chronic kidney disease. Chronic kidney disease, basically the synthesis of vitamin D3 is reducing. If vitamin D3 is reducing, calcium is reducing. Because of the feedback mechanism, PTH is going to increase. If you want to know the mechanism which they usually ask with respect to how does vitamin D3, the active one called calcitriol, is formed. See, in the skin, 7-dehydroxycholesterol with the help of UV light is going to be converted to vitamin D1, that is going to call the calciferol. In the liver, this is converted into 25-hydroxycalcidiol because it is D2, and in the kidney with the help of enzyme which is alpha hydroxylase, it gets converted into the active form which is 1,25-hydroxycalcitriol. Alright, this is secondary hyperparathyroidism. In secondary hyperparathyroidism, you'll have pathological rib fractures. Again, why? PTH is increasing, it is causing bone resorption and thereby the bone is getting weak. And this is known as von Recklinghausen disease of the bone, also known as osteitis cystica fibrosis. Von Recklinghausen disease is known as another thing in case of a skin condition. Comment below what it is, and that is a previous year question. When the patient begins to bleed, you'll have classic findings of hemosiderin, and that is why this is also known as brown tumor. Now see, the treatment of hyperparathyroidism causes hypercalcemia. So we were treating the calcemia in primary hyperparathyroidism. In secondary hyperparathyroidism, the issue is that there is too much PTH. So let's do one thing, let's inhibit PTH. To inhibit PTH, we have a drug that is known as cinacalcet. So remember, in case of secondary hyperparathyroidism, the drug of choice is going to be cinacalcet, whereas in primary hyperparathyroidism, the drug of choice was bisphosphonates. You can see a classic differentiation in primary hyperparathyroidism. There was an adenoma. The adenoma caused a PTH increase. Because the PTH increased, calcium was increased, the phosphate was decreased, and the SAP also obviously increased. In secondary hyperparathyroidism, the vitamin D3 is less. If vitamin D3 is less, calcium is going to be less. Now, because the calcium is less, the feedback pathway gets activated, thereby PTH is going to be elevated, and again SAP is going to be elevated. So the classic difference is in the level of calcium. Okay, here are the treatment management, and we are done with primary and secondary hyperparathyroidism. Second condition we will be talking about is osteoporosis. Basically, osteoporosis means decrease in the bone density. Because of bone resorption, there is decrease in bone density, and that bone is now fragile and prone to fractures. Now, if you want to talk with respect to definitions, we are going to do a bone density scan, which is known as a DEXA scan. A DEXA scan ka full form is dual energy X-ray absorptiometry. You have two scores, that is a T score and a Z score. Whenever your value of the T and Z score is more than minus 2.5, by more I mean it is 2.5, 2.6, 2.7, minus 3, that is known as osteoporosis. Now another condition is known as osteopenia. The basic difference is in both they have a decreased bone mineral density, but osteopenia is a less severe condition than osteoporosis, which means the osteopenia level is going to be between minus 1 to minus 2.5. And osteoporosis is going to be more than minus 2.5. This is basically a bone density issue. That is why you will see a classic history. The calcium level is normal, phosphate is normal, and the SAP is also normal. Why the serum alkaline phosphate is normal? Because the PTH is also normal. Okay, for these again the treatment of choice is going to be bisphosphonates. Why? As I told you, the mode of action, that's why pharmacology is very important. Bisphosphonate inhibits the activity of osteoclast, and osteoclast is responsible for bone resorption, and bone resorption causes osteoporosis. That is why over here we're giving the drug of choice is going to be bisphosphonates. Let's talk about the drug of choice one more time, so we're revising at the same time. Primary parathyroidism, the drug of choice was going to be bisphosphonates. Secondary hyperparathyroidism, the drug of choice was to inhibit PTH, so we gave cinacalcet. In case of osteoporosis, the drug of choice is going to be bisphosphonates. Sorted? A next condition is whenever a patient has maybe a toxic nodule or maybe a thyroid cancer, and we have to do a surgery of the thyroid gland. As I told you, the parathyroid, the four ones, are present behind the parathyroid, behind the thyroid gland. So sometime when we are removing the thyroid, accidentally the parathyroid glands are also removed. If the parathyroid glands are removed, PTH level is going to go down. If PTH level is going to go down, calcium level also will go down, phosphate level is going to go high, and the SAP is also going to go down, right? So because calcium level is going to go down, the main side effects are going to be hypocalcemic side effects. So classically you will have a post-operative tetany because of hypocalcemia. This tetany can be presented in two ways. One is going to be known as a chopstick sign. Chopstick sign is when I'm going to tap the anterior border of the parotid gland, there will be the eye will begin to flick. This is because of the facial nerve irritation. Second is, this is known as a Trousseau sign. What is Trousseau sign? Basically, I'm going to take a BP cuff. I'm going to increase the pressure up to 20 mm of Hg for 3 minutes, and then you will see a carpopedal spasm. This carpopedal spasm is because of hypocalcemia. This is causing irritation to the median nerve, and this is also known as the obstetrician's hand. Simple. Hypocalcemia can cause death, and the cause of death is going to be laryngospasm whenever the value is less than 7. Remember, if the value is more than 15, it is causing systolic arrest. Diastolic arrest was caused by hyperkalemia. All right, so then workup, as I told you, calcium is going to be low, phosphate level is going to be more, and the SAP is going to be normal. Now the reason why SAP is normal is the classic history, because like as I told you, it should go normal. So it can be normal or it can go reduced because the parathyroid is basically not functioning anymore. But since the parathyroid is not getting affected, the osteoclast cells are not getting involved. That is why the SAP is going to be normal. The main factor is osteoblast. And osteoblast is getting triggered whenever there is an increase in parathyroid. If there is no increase in parathyroid, because there is no parathyroid, the osteoblast is not going to get activated. Thereby, the serum alkaline phosphatase is going to be normal. So kindly correct that thing which I earlier said. Calcium again is going to go low, phosphate is going to go high, but SAP is going to be normal. Now because hypocalcemia causes contraction, and because calcium causes contraction, hypocalcemia, which means reduced contraction, that is why your QT interval is going to be prolonged. If calcium is low, let's give calcium. So that's why you're going to give IV calcium gluconate, that is 10% over 10 minutes. All right. If you have a surgery-induced hyperparathyroidism. Now, hyperparathyroidism means PTH is low. So now we have to give PTH, right? So this is a treatment-induced hypoparathyroidism. So T for treatment and T for teriparatide. T for treatment and T for teriparatide. Again, let's revise. Just imagine that we are having a live class and you're answering, and be loud. Don't keep it in your mind, be loud. First, we talked about primary hyperparathyroidism. The drug of choice was bisphosphonates. Second, we talked about secondary hyperthyroidism. We had to inhibit PTH. So that's why we gave cinacalcet. Third, we talked about osteoporosis. The drug of choice was bisphosphonates again. And in fourth condition, which we're talking right now, is hypocalcemia. In case of hypocalcemia, which is induced by a treatment, which was removal of the thyroid. So T for thyroid, T for treatment, and T for teriparatide. And teriparatide is going to increase the parathyroid hormone. Remember, Doc Saab, that calcium, whenever it is increased more than 15, you can cause systolic arrest. And if your calcium is too much, the drug of choice is going to be ibradronate. Remember, in primary hyperparathyroidism, the drug of choice was bisphosphonates. It is ibradronate. Second condition, whenever you have hypocalcemia less than 7, patient can get laryngospasm. There will be no air supply. Patient can die. If there is hypocalcemia, give them 10% calcium gluconate. As I already told you, diastolic arrest is because of hyperkalemia. And whenever there is hyperkalemia, again, you're going to give 10% calcium gluconate. Hypokalemia values which are less than 3.5, severe is less than 2.5. If there is severe hypokalemia, patient can have diaphragmatic paralysis and then thereby die. So in case of hypokalemia, if there is less potassium, just give more potassium. So you give KCl plus IV fluids. I hope this was very simple. This topic, I try to make this as simple as possible, and you will not get confused with respect to what is increasing, what is decreasing again. Since we're talking about hyper and hypokalemia, let's talk about the details with respect to potassium because it's very important. You need to know that with respect to hyperkalemia and hypokalemia, first thing is the basics. Potassium 98% is within the cell and 2% is in the extracellular fluid or in the blood. Alright, the normal value is between 3.5 to 5 milli equivalents. So basically you have two conditions. One is going to be hyperkalemia and other condition is hypokalemia. Let us talk about hyperkalemia first. Now whenever you have hyperkalemia, which means there is too much potassium in the body, there are multiple causes. One cause is maybe someone is taking too much potassium supplements. Second is kidney failure. Now why kidney failure? Because potassium is excreted via the kidneys. So if the kidney functioning is not there, potassium will not be excreted and thereby increase in potassium will be there within the body. Third condition is hypoaldosteronism. Now aldosterone is a hormone which causes increased uptake of sodium with the exchange of potassium outside. So if there is less aldosterone, there won't be potassium going out of the body, thereby hyperkalemia. Third is rhabdomyolysis. Rhabdomyolysis basically means muscle breakdown, and within the muscle, as I told you, 98% is within the cells. Everything comes out. Patient is going to suffer from hyperkalemia. Drugs, spironolactone. What is spironolactone? The mode of action of spironolactone is it inhibits aldosterone. And if aldosterone is inhibited, as we earlier said, potassium will not go outside. Drugs like NSAIDs, a very important ACE inhibitors, causes hyperkalemia. So very important PYQ, make sure you know that spironolactone, NSAIDs, hyperkalemia, conditions like chronic kidney disease, rhabdomyolysis, hypoaldosteronism, metabolic acidosis, all causes hyperkalemia. What are the symptoms? Patient is going to complain of muscle fatigue, muscle pain, muscle numbness. Now everything is high. Hyperkalemia. Patient is going to have palpitations, tremors, anxiety, dysarrhythmias, and as I told you, if there is too much hyperkalemia, patient can die because of a diastolic arrest. Now talking about hypokalemia, the causes of hypokalemia is if the patient is vomiting a lot, too much vomit will be there, or too much diarrhea. What are the drugs? Remember we talked about furosemide in case of hypercalcemia. Here also, whenever patient is going to have like too much use of Lasix, it is going to cause excretion because it is a loop diuretic which is going to remove potassium and calcium, so patient can suffer from hypokalemia. Again, the symptoms are going to be same: muscle weakness, myalgia, tremors. Patient can have decrease in motility. So remember, hypokalemia, hypomotility, constipation. Okay, classic history, the drugs which will be, as I told you, furosemides, steroids, dialysis, and diabetic insipidus. So this is all about hypo and hyperkalemia. Now very important part in case of hypo and hyperkalemia is the ECG changes. Now what you have to remember is that first, in normal PQRS there is a P wave which is atrial depolarization, QRS that is ventricular depolarization, and then you have a T wave which is ventricular repolarization. R for repolarization, R for relaxation, and both the P and QRS are for contraction. Potassium is a relaxing hormone. Okay, potassium is a relaxing hormone. Whenever potassium is going to be too much, there is going to be increase in the T wave because T wave is also relaxing. So whenever you will have an increase in potassium, you will have increase in the T wave. Okay, and this is not actually the accurate one. It's going to be a tall tented T wave, a narrow T wave. Okay, while if you see there is a decrease in potassium, you will have T wave inversion, because decreased potassium means less relaxation, so the T wave is going to be inverted and small. Okay, let's talk about it in detail. First of all, hypocalcemia is less than 3.5 milliequivalents. You have 3 degrees: mild, moderate, severe. Severe is less than 2.5, mild is between 3 to 3.5, and moderate is between the range. So remember, the severe one is less than 2.5, and then along with this the ECG changes. Now as I told you, if it is hypokalemia, hypokalemia means the relaxation is less, so there will be first sign is going to be T wave inversion. After this, what is going to happen is the ST follows the T wave. That is why you will have a T wave, and along with that an ST depression. So because there is an ST depression, and remember there is like the classic case what you see in hypokalemia is that since the relaxation is less, you will also have a something, it's not given in this graph, you will have a pseudo P pulmonale. Okay, a pseudo P pulmonale, which is mostly because of a right atrial enlargement, but because the relaxation is less, the P wave is going to be taller. The T wave starting sign is going to be inversion followed by ST depression. Okay, now the cause of death in case of severe hypokalemia can be ventricular fibrillation or a condition which is known as torsades de Pons. And the drug of choice for torsades de Pons is going to be in IV magnesium sulfate. Okay, IV magnesium sulfate, another pharmacology addition. Now this is about hypokalemia. So remember, hypokalemia, potassium is relaxing. If less, so less relaxation. T wave is a relaxing part, so it's going to be less, followed by ST depression and a pseudo P pulmonale. If you talk about hyperkalemia, anything more than 5.5, you have three ranges: mild, moderate, severe. Severe is going to be more than 7.5. If you talk about hyperkalemia, so it is means more relaxation. If it is going to be more, then you'll see the T wave is going to be tall. Now you can see one thing, in ST elevation also you'll have a tall T wave. So how do you differentiate amongst both of them? In both of them you will see, first thing is that in case of MI, it is going to be a broad part, while in case of hyperkalemia it is going to be narrow. This is going to be tall and symmetric, and this is not. Then along with this, the other part is going to be a blunted peak. This is going to be sharp, and then again the base. So first sign in case of hyperkalemia is going to be tall tented T waves. Second thing is, because it is going to be a relaxing part, so what relaxation is going to be more, obviously then the QRS part is going to be broadened, because QRS is going to be ventricular depolarization. It is going to affect it. P wave is also a contracting part. Because of hyperkalemia you will have a loss of P wave, and also they can say a type of absent P wave. So then they will ask you a condition, which are the conditions where do you see absent P wave? Absent P wave is classically seen in atrial fibrillation, in case of sick sinus syndrome, and right now which we talked about, hyperkalemia. So remember, hyperkalemia has tall tented T waves, the QRS is going to get broad, and then you will have absent P waves. Very important. Now if patient is having severe grade of hyperkalemia, the T wave and the QRS combine together to form something which is known as a sinus pattern, and this is going to cause death. Okay, so these are the classic signs. Basically, if you want to know about hypokalemia and hyperkalemia, remember in hypokalemia there is T wave inversion, right? So then, and hyperkalemia, the arrow is going up and there is going to be a tall tented T wave. So that is going to be an easy explanation of hypo and hyperkalemia. So as I told you, normal levels is 3.5 to 5.5. Hyperkalemia has tall tented T waves. Furthermore will be sinus pattern. Potassium is repolarization. So thereby all parts of depolarization parts are going to decrease. P wave is going to be absent. QRS is going to get broad, and the death is caused by a sine wave pattern. So if you ask what is the treatment of hyperkalemia, the first step is going to be 10% calcium gluconate over 10 minutes. Second is the best drug, that is going to be insulin drips, because insulin causes the intake of potassium within the cell. That is why in case of diabetic ketoacidosis also, before giving insulin we always check the potassium levels, so that we don't cause hypokalemia in the body. You will have salbutamol nebulization. Okay, in a higher dose it does cause effect. Furosemides, again remember furosemide, a very important drug. It is a loop diuretic, so that is why it causes excretion of potassium. So remember how I remember is furosemide, F for furosemide, F for flow out. So flow out calcium and potassium. So both in case of hypercalcemia and hyperkalemia you can use furosemide. They are going to ask you the most effective drug in reducing potassium. If you will see, that is going to be insulin drip. Remember guys, that calcium gluconate over here doesn't reduce the potassium level. Very important, it causes stabilization. Okay, this is a very important topic. It causes stabilization of the cardiac membranes to prevent arrhythmias. Okay, so that is why we're giving this the first time we're giving this. This is an emergency medicine. We'll talk about this in detail, but calcium gluconate causes the membrane stabilization. It doesn't cause decrease in the potassium. The drug which is decreasing potassium is over here going to be insulin. The best drug is insulin, and the best effective method, which if you talk about, is going to be hemodialysis. Okay, because the route of excretion of potassium is going to be renal. So thereby there is very less to mug up. It's all logic, correct? Hypokalemia, just now we told hypokalemia means less rest. So just remember potassium is going down, so the T wave will also go down. First is T wave inversion. The ST is also going to go down. That is ST depression. You'll have something which is known as pseudo P pulmonale. We already discussed about it. Potassium levels, if it is going to go less, very severe, less than 2.5, patient can die from diaphragmatic paralysis, and the drug is going to be KCl plus IV fluids. All right. So remember, we talked about 4 conditions: systolic arrest, hypercalcemia, diastolic arrest. If you see, that is hyperkalemia. In case of hypocalcemia, patient can die because of laryngospasm. And in case of hypokalemia, patient can die because of diaphragmatic paralysis. Hyper and hypothyroidism. Next topic. So hyperthyroidism and hypo, whenever we talk about hyper and hypo, we are not talking about TSH. We are talking about T3 and T4. Obviously TSH is going to be important part over here, but remember, whenever you define, so that you don't get confused, hyper or hypo, it is based on the T3 and the T4 value. Hyperthyroidism basically means T3, T4 is going to be elevated. If now primary hyperthyroidism is a condition in which the T3 and T4 is already elevated. Now if T3 and T4 is already elevated, because of the feedback mechanism, it's going to tell our brain, don't secrete more TSH. So that is why the TSH is going to be low. This condition is known as Graves' disease. The antibody which is seen in Graves' disease is going to be thyroid stimulating immunoglobulin. Okay, so it's going to be a thyroid stimulating immunoglobulin. This is primary hyperthyroidism. Secondary hyperthyroidism is a condition in which you will have a tumor. Now because there is a tumor already in the brain, everything is going to start secreting too much. So that is why thyroid stimulating hormone is already going to secrete too much, and this is going to go and act on the thyroid gland, thereby more T3, T4. So remember, a classic case, a Graves' disease, T3, T4 is already very high, so it is going to signal the brain, don't secrete too much TSH. Secondary hyperthyroidism is a condition where there is a tumor. This tumor is going to secrete too much TSH, and this too much TSH is going to act on the thyroid gland and cause increased T3, T4. Hypothyroidism. Hypothyroidism means T3, T4 is going to be low. Now if you talk about low T3, T4, so then it is going to go and signal the brain that we need more T3, T4. So that is why in this condition the TSH is going to be more. Primary hypothyroidism is going to be known as Hashimoto's thyroiditis. It is an autoimmune disease. The antibody over here is going to be anti-TPO antibody. Very important part. Alright. So remember, in Graves' disease it was thyroid stimulating immunoglobulin, while in case of hypothyroidism it is going to be Hashimoto's thyroiditis, and that is going to be anti-TPO, that is thyroid peroxidase. Secondary hypothyroidism. Now secondary hypothyroidism is because there is a condition that is known as Sheehan syndrome. Now Sheehan syndrome is causing atrophy. Because of atrophy, TSH is going to be less. If TSH is going to be less, no one will help the thyroid gland to build T3, T4. That is why T3, T4 is also going to be less. I hope you understood the whole concept of hyper and hyperthyroidism in this slide. Now this condition, whenever you see, this is known as pre-tibial, in front of the tibia, maxedema, fluid filled region. This area is because of pre-tibial maxedema. This is basically lymph, so this is a lymphedema, and inside this you will see GAG, which is galactosaminoglycans, biochemistry. Okay, so classic history, this is seen in a hyperthyroid patient. So you will have a young patient who has heat intolerance. She will have tremors, palpitation, weight loss because of increased basic metabolic rate. In case of hyperthyroidism, everything is working very fast, and this is pre-tibial maxedema, as I already told, and this primary hyperthyroidism, so it is Graves' disease. Remember, the drug of choice in case of Graves' disease is carbimazole and methimazole. Mainly prefer carbimazole. But very important condition, if a patient is pregnant, and if you'll ask what is the first trimester drug of choice in case of a pregnant female, that is going to be PTU. PTU stands for propyl thiouracil. Why? Because carbimazole and methimazole in the first trimester causes a defect which is known as alopecia cutis. Okay, but remember, PTU also has its own problem. It has a black box warning of hepatotoxicity. Okay, it has a black box warning of hepatotoxicity. Next, now we are sorted with hypo and hyperparathyroidism, and another problem in life is what is subclinical and what is clinical. All right, subclinical clinical hypothyroidism is very simple to understand. Let's talk about the subclinical part, and I'll tell you what the clinical part. Basically, the meaning of clinical is whenever you see signs and symptoms. So basically, in case of hypothyroidism, you know that the T3 and T4 is going to be low, so TSH is going to be high. What happens in subclinical hypothyroidism is that the TSH level is anyway going to be high, but the T3 and T4 is going to be normal. So we are deciding the word hypothyroidism based on the TSH level. Subclinical hyperthyroidism, which means the TSH level is going to be low, but the T3 and T4 is going to be normal. Basically, when we talk about clinical hyperthyroidism, what we talked about is that the hyperthyroidism is the T3 and T4 level is going to be high. That is why TSH is going to be low. Over here, the TSH is anyway low, but the T3 and T4 is going to be normal. The word clinical means effect, and the effect is mainly caused by T3 and T4. So when the T3 and T4 levels are normal, you will just add the word subclinical. Talking about primary hyperthyroidism, Graves' disease, what are the signs? First of all, the treatment of choice is going to be radio ablation, and radio ablation is going to be used by beta rays. This is a radiology topic, we'll talk about it later, but remember the iodine used for this is I-131. There are multiple types, I-131, I-123, but we are going to use I-131 because the half-life of this is also going to be 8 days. The treatment of choice, again, as I told you, the drug of choice, the next thing is going to be carbimazole more than methimazole. Carbimazole is not preferred in the first trimester of pregnancy. You will give PTU. Okay, over here you can see the staring eyes. Okay, the staring eyes is because of lid retraction. Basically what happens is the antibodies in the thyroid, they go around the eye and cause inflammation. So this will cause an inflammation of the muscle that is known as the Muller muscle. Let's add ophthalmology. There are two muscles which are responsible for lid retraction. One is the levator palpeus superioris, and the other one is going to be your Muller muscle. Remember, the Muller muscle is the one which is involved in case of the lid retraction in hyperthyroidism. You will have another condition, you can see the eyes are popping out, that is known as proptosis. The reason of proptosis is because of the inflammation caused behind the eye is popping out. Because of the inflammation behind the eye, it can cause retrobulbar neuritis, and retrobulbar neuritis causes blindness in case of hyperthyroid patients. As I told you, thyroid means everything. The basic metabolic rate is very fast. If the basic metabolic rate is very fast, the patient is going to have weight loss. Calorigenesis, too much heat is producing. That's why they are very intolerant, especially in the summer. Too much garmi, too much hot, too much hot. Symptomatic effect. The symptomatic effect is basically patient is going to have tremors, palpitations, signs of arrhythmia, sweating, and hypertension. Very important, hypertension as well. If you talk about the dermatopathy, we just now talked about pretibial myxedema, that is lymphedema, right? Workup, remember in case of hyperthyroidism, T3, T4 are elevated, TSH is going to be low, right? Remember the free value, there is two types. One is going to be the ionized and the free part. The free part is the one which is going to be free, and the active part which will be used. Remember, the majority of the thyroid is going to be T4, which is going to get converted into T3 with the help of an enzyme which is known as D1 deiodinase. Remember D1 deiodinase. So D1 is going to be the one which is going to convert it. All right. So if you talk about how to investigate the levels, like how to investigate what type of thyroid issue there is known as radioactive iodine uptake. Now whenever an part of the thyroid gland is going to take too much uptake, this is going to be black in color. Okay, so more uptake means more black in color. Cold nodule over here, suggestive of a malignancy. More black throughout with a classic sign of a pyramid lobe, this is Graves' disease. A mix of, you will see hot and cold, this is classically a toxic multinodular goiter. Hot nodule, only one black, and these are the following conditions which you need to know. See over here, in case of Hashimoto thyroiditis, there is no uptake because there is no T3, T4. That is why you will see it is completely white in nature. Again, we were talking about hypothyroidism. Hypothyroidism, a female will be having decreased basic metabolic rate, so patient will have weight gain. Calorigenesis is reduced, so patient will have cold intolerance, especially in winter. They will have a puffy face. They will have alopecia, and the alopecia seen in case of hypothyroidism is going to be alopecia areata. Hypothyroidism, another blood effect which you see is going to be a macrocytic anemia. Very important, is going to be macrocytic anemia. So now the differentials, remember, if a patient finds with macrocytic anemia more than 100, if you'll see, that is going to be vitamin B12 deficiency, folic acid deficiency, chronic liver disease, and now which we just now talked about, hypothyroidism. Okay, very important. So along with this, you will have a dry skin in hypothyroidism. Patient will have hoarseness of voice. Remember, in case of hypothyroidism, there is increase in total peripheral vascular resistance. Because of this increase in total peripheral vascular resistance, patient is going to have headache and hypertension. Okay. There, in case we had pre-tibial myxedema in case of hyperthyroidism, over here you have something which is known as myxedema coma and myxedema madness. Madness are the psychosis associated with hypothyroidism, which can be hallucination and delirium effects. Now, in case of hypothyroidism, the heart rate is going to be reduced. Okay, in hypothyroidism, patient is going to have reduced heart rate. That's why you can have some type of block, which is a first degree type of block. All right. Patient can have increase in BP, as I told, because of increase in peripheral vascular resistance. And the investigation, if you see, a reliable sign is going to be the hung up ankle test. What are you going to do is you're going to go and just imagine if this is going to be the ankle down there. If you're going to go and pick it over here, the muscle will have slow relaxation. The soleus and the gastrocnemius muscles are going to have slow relaxation. That is known as hung up ankle sign. Okay, you can have serious cavity effusions, which is like pleural or pericardial effusions, increased risk of heart attack because of atherosclerosis, and as I right now told you, macrocytic anemia can also be seen in hypothyroidism. If you talk about the reports, hypothyroidism, T3, T4 are going to be low, TSH is going to be elevated. Now, important condition is if the TSH level is very high and T3, T level, this is known as primary hypothyroidism. This is Hashimoto's thyroiditis. You'll have anti-TPO. Second condition, if TSH is also low and T3, T4 low, this is secondary hypothyroidism, and this is mostly associated with a condition like Sheehan syndrome. Okay. If you talk about the treatment of hypothyroidism, which mostly everyone does, is levothyroxine. You give a slow dose of 25 microgram and slowly increase it up to 100. But this is a condition of a already tolerable condition of thyroid issues like hypothyroidism. If you have a history of patient who is having hypothyroidism, patient had an intercurrent illness like UTI, stroke or MI, and the patient is also hypothermic, which is less than 35, this condition is known as myxedema coma. Over here, you need urgent level of T3. Remember, in the thyroid gland, majority is T4 and the active form of thyroid is T3. T4 is converted to T3 with the help of D1 deiodinase, and now in myxedema coma, we don't have time for T4 then T3. So we directly give your T3 in the form of levothyroxine. Remember, levothyroxine is T4, all right? And in case of myxedema coma, we are giving levothyroxine. So this is all what you need to know with respect to hypo and hyperparathyroidism, hypo and hyperthyroidism, and potassium related issues. I really request you guys to comment how did you like this lecture, because really it takes a lot of time. I'm trying to manage, it's right now 4 in the morning and I'm trying to do this videos. I would really appreciate your comments and how did you like it and how do you want me to improve this, as we are going to complete the entire subject and much more. Take care, follow Jabstudiesmetfun, and Doc Saab, you got this. See you on the next slide.